I'm Vital Rao, upper GI and bariatric surgeon. I'd like to take this opportunity to thank the Royal College for this opportunity to host the RSA webinar series for medical undergraduates. It's my pleasure and privilege to introduce today's speaker in the Royal College webinar, Ms. Cynthia Bogg. Ms. Cynthia Bogg qualified from the University of Malta in 1997 and went on to complete her MD from the University of London, focusing on changes in gut hormones after bariatric surgery. Ms. Bogg completed her specialist surgical training in upper GI and bariatric surgery in London in 2012. Cynthia was appointed as a lead consultant surgeon at the University Hospital Lewisham. A specialist clinical and research interests bariatric and metabolic surgery besides laparoscopic abdominal surgery, including gallstones and gastroesophageal reflux. Ms. Bogg has published extensively in peer-reviewed journals, is a reviewer for several international journals, and is president in national and international meetings. She is a regional surgical advisor of the Royal College of Surgeons of Edinburgh. Cynthia is also an elected council member of the British Obesity and Metabolic Surgery Society and of the Association of GI Surgery of Great Britain and Ireland. So today's topic is on gastroesophageal reflux, otherwise called GORD or GERD, depending upon which side of the pond you are, and hiatus hernias. It's a very common yet poorly understood clinical problem, both among patients and medical personnel. So before I give up the floor to Cynthia, can I ask all of you to use the question and answer facility at the bottom of your screens to ask questions? And if you want the questions to be answered by the speaker, please use the thumbs up symbol. Cynthia, the floor is yours.
Thank you very much, Vital, for a kind introduction, and thank you for the college for yet again inviting me to do this webinar with you today. Hope you're all well. So this is what we're going to talk about today. Gastroesophageal reflux is the commonest upper GI complaint, and it has been estimated that 10 to 20% of the general population in the West suffer from this on a weekly basis. I'm sure that most of you would have experienced reflux symptoms either after or before an exam or after a night at the pub. The typical symptoms of reflux include retrosternal burning pain or heartburn, epigastric pain that may be provoked by food, and regurgitation. Regurgitation is effortless food or fluid coming up to the mouth. The patients sometimes describe it as water or acid breath or an acid taste in the mouth. It usually occurs either nocturnal, so the patients would tell you that they wake up with an acidy taste in the morning. Sometimes it wakes them up at night, and sometimes it can happen when they bend. Less common symptoms can include pain on eating or oesophageal, throat pain, sometimes hoarseness or voice change, dysphagia, fullness and bloating, and chest symptoms like coughing or recurrent chest infections. It is very important when you're seeing these patients to listen to what they're saying, but also to probe and ask questions like the duration of the symptoms. Is this just related to a period of stress in their life? What is their weight doing? Are they putting on weight or are they losing weight? Whether they have tried any off-the-counter medication. I mean, right now even PPIs are available over the counter. Have they been having antacids? Has it responded to lifestyle measures like stopping alcohol, for example, and whether they have any risk factors like obesity? It is very important to ask these probing questions because some of the symptoms, like dysphagia, can be a red flag symptom, and we will talk about this more when we talk about investigations. There are some other symptoms like regurgitation or chest symptoms that respond poorly to the most common therapy modality, which is the PPIs. Again, we'll talk about this a little bit later on. So, what maintains normal competence of the gastroesophageal junction? So here we can see the diaphragm. As you know, it's a big thin muscle between the chest and the abdomen, and it's got three foramina in it. The central one in the level of T10 is the oesophageal hiatus, which you can see marked there. To the right and above it at around T8, there's the IVC foramen, and below it and a little bit lower at T12 level, you will find the hiatus where the lower aorta, the abdominal aorta, goes through. You can also see the picture from the thorax here, from the thoracic side. You can see the lungs, and deep in the posterior mediastinum, very posteriorly, just abutting on the vertebra, you can see the esophagus there going in through the diaphragm, through the esophageal hiatus. These are from the Ackland Atlas, and as if you are college affiliates, you would have access to this very brilliant resource as part of your membership. So this is a lovely diagram about the lower esophageal sphincter complex. So what you have is the esophagus, and the esophagus is, as you know, has got two layers of muscle, the circular inner layer and then the longitudinal one. If you have a feel of an esophagus, you don't actually feel a sphincter. It's not like the pylorus. It's not, you know, it's not like a rigid or a more firmer structure, yeah? But together with the diaphragm and together with the phrenosophageal ligament, it forms part of the lower esophageal sphincter complex. The sphincter complex relaxes as a coordinated part of swallowing. It also relaxes when you need to vomit, or when you have air trapped in the fundus, and to allow air to vent. It also relaxes without swallowing as part of a reflex called transient lower esophageal relaxation. When we get these transient lower esophageal relaxation, sometimes when we get more of them, yeah, we can get that in the early stages of GORD. Later, the pressure itself in the lower esophageal sphincter becomes low, and there will be sometimes loss of the adequate length of intra-abdominal esophagus. Yeah, so usually there's 2 centimeters of intra-abdominal esophagus. Sometimes when a patient develops a hernia, that disappears. So this is a less lovely diagram that I drew only this morning to explain to you a little bit better. So we have the diaphragm. As you can see, we've got that 2 centimeters of lower esophagus that's in the abdomen. We've got the fundus, and we've got the cardia that's just proximal to the GO junction. Now, what happens when people have hernias? The commonest type is a sliding type. Yeah, it's about 90%. So what happens is that the space in between those crura that we could see in the earlier diagram, that sling around the esophagus, that actually opens up, that relaxes. So that allows the stomach and the cardia to go up to the chest. So you can see where the lower esophageal sphincter was, yeah, it's now up in the chest. Another type of hiatal hernia, albeit very rare, about 3%, is what we call a true paraesophageal hernia. And what we get in this is the fundus going up to the chest while the lower esophageal sphincter stays in place. This type of hernia is the one that's more likely to strangulate. So sometimes we see it in people like 80-year-old ladies, and because that gap is sometimes narrow, what can happen is that that bit of stomach can strangulate, i.e. can become ischemic and sometimes even die. And that obviously will be rather an emergency. The other type of hiatal hernia that we can have is a combination of type 1 and type 2. It can happen in 7% of cases where we have the lower esophageal sphincter in the thorax as well as the cardia and the fundus. Sometimes in these cases we also get other organs like the colon going up. Sometimes you see the spleen going up as well. So it makes the operation much more complex. So, pathological reflux is chronic acid and/or bile reflux causing the unacceptable symptoms that we have described. Obviously, if they persist, they may become quite unacceptable, or else the patients have demonstrable pathology. So how are we going to demonstrate that pathology? What investigations are we going to do? The investigation of choice, and the one that we usually start with, is an upper GI endoscopy, an OGD. That's usually done either with throat spray or with some sedation. Very rarely a general anesthetic is needed. Usually lasts about 10 minutes, and it's usually done as a day case. So what you can see in the middle is what a normal gastroesophageal junction looks like. You can see the sort of the indentation from the diaphragm, and that at that moment the GOJ was closed. What you then can see on the other side is inflammation, oesophagitis. Yeah, so there are different classifications of oesophagitis. Most people use the LA classification, and this what you can see here is quite extensive. Those red marks are sort of where the little ulcers and the inflammation from the acid or the bile have occurred. We can also use the OGD to see complications of reflux. So we can see here in the first picture on the left, we can see a stricture. So it has been inflamed, and as a result, it has fibrosed, it has narrowed. What we can see in the middle is Barrett's esophagus, and Barrett's esophagus is the change from the usual squamous lining, the pale pink lining that we can see, that we saw in the normal picture here, to a columnar lining. And one of the risks of that is that there is a small chance of dysplasia and malignancy. And then what we can see on the right is actually an adenocarcinoma that can sometimes occur and can sometimes present with similar symptoms to reflux, with worsening reflux, and especially with dysphagia. So that's why dysphagia is a red flag symptom. Other things that we can use is a barium upper GI study, where we give the patient barium or gastrografin to drink, and we follow it down the esophagus and down to the stomach as it goes down. So the patient's drinking, and the x-rays are taken while they're drinking. Other things that we can do are pH studies. So we're actually checking the pH in vivo with the patient. We can do it via a catheter study for 24 hours. So it's like a fine bore NG tube that passes through the nose, and the patient goes home with it for 24 hours. And they're advised to just keep on doing what they normally would do with the catheter in situ. And sometimes we also, especially if the patient does not tolerate that study, sometimes we do a Bravo test, which is a little capsule that's put into the esophagus at a certain distance from the GOJ endoscopically. And then you have a little monitor, which this little capsule sort of transmits to, and it usually stays there for about 3 or 4 days and then is expelled with the feces. We can also do manometry. So while the pH told us what's happening in the lumen with the actual acidity, the manometry tells us what's happening regarding the motility, the muscle. Do you have normal swallowing? Is the peristalsis normal? Are things going up? Are things staying down? And the most recent form is this high resolution manometry, where you get lots of data, yeah, and then usually a specialist physiologist analyzes this data to give us a comprehensive report. Sometimes we use CT scans as well to tell us about especially if we're thinking about paroesophageal hernias. Now, what is the management? So whenever you're asked about management, whatever people ask you, you can always more or less divide them into 3 or 4. There's conservative management, medical management, surgical, and sometimes there are also endoscopic options. So, most patients have very short-lived episodes of reflux, so they live with it, they change their life, they self-medicate. Sometimes they try to lose weight. Certainly, obesity is one of the risk factors. We know that patients suffering from obesity or even morbid obesity have about 3 times the chances of experiencing symptoms of reflux. So avoiding precipitants, smoking cessation, raising the head of the bed, and avoiding large meals before they go to bed. There is a very comprehensive, nice guidelines for reflux in adults, as well as there is another document about reflux in children and adolescents. Obviously, being this common, it is actually the single biggest pharmaceutical expenditure in the UK NHS. So obviously, you don't want patients to be on long-term PPIs or long-term therapy if they can avoid it. So this is what the NICE guidelines would suggest. So if you have reflux, the GP usually would put you on a 4 to 8 weeks supply of proton pump inhibitors at standard doses. If the symptoms are much more severe, they're really impacting on your quality of life, they may extend the treatment dose, as well as if you have chronic recurrent symptoms. Sometimes they put you on the lowest dose that they can, making sure that your symptoms are controlled. Sometimes if there's inadequate responses, we try H2 receptor blockers. So what are we doing here? What we're doing is try to eliminate the acid exposure of the lower esophagus. We are not stopping the reflux. So we're changing the stuff coming up from acidic, pH of 2 or less with the stomach, to something that is pH neutral. We still don't have medication to actually stop the actual reflux. There are different PPIs, yeah. They vary in when they were sort of introduced in the market. They also vary in cost, and always check your hospital formulary regarding what you can prescribe. They do have some potential adverse effects, which from time to time appear on the Daily Mail as the sort of new the new problem. So they have been associated with things like osteoporosis, hypomagnesemia, chronic kidney disease, C. diff infections, and dementia. I mean, certainly if you need a PPI, if they improve your quality of life, certainly you should have it. But obviously GPs, that's why GPs and that's why upper GI surgeons and gastroenterologists will, take you off them if you don't need them. So in terms of most patients do not need investigations. However, there's a small group of patients that need a rapid access endoscopy. So there are those with dysphagia, And they are those who are 55 or over with weight loss and who have either pain, upper reflux, or dyspepsia. So it's very important not to miss those important questions that we discussed earlier. These are the red flag symptoms. Also, most GPs would consider referral to a specialist service, usually either an upper GI surgeon or a gastroenterologist, if the symptoms are non-responsive or unexplained, or if the patient wants to consider surgery. So that brings us nicely to surgery. So what are the indications for surgery? Patient's choice. If the patient has had enough of having their reflux, or if the patients are still getting that volume reflux, that regurgitation, which we know is poorly controlled with the PPIs, because even though the stuff is acid neutral, pH neutral, it's anyway coming up. So especially in patients that are getting sort of stuff going up to their mouths whenever they bend, whenever they try to go to sleep, waking up coughing at night, either waking themselves up or their partners up, that is sometimes, especially in younger patients, affects their quality of life, and they want to consider surgery. Also, regarding breakthrough symptoms, despite maximal PPIs, larger hiatus hernias, as we said with the paraesophageals, most paraesophageal hernias, if they are fit, they come to see us to discuss the pros and cons, and intolerance, non-compliance, or concerns with PPIs. So what can we offer? We can offer laparoscopic fundoplication, or else sphincter augmentation. The commonest thing, certainly in my practice, would be a laparoscopic fundoplication. What do we do in the laparoscopic fundoplication? So first of all, we dissect the hernia and reduce it back into the abdomen. We mobilize the lower esophagus to make sure that we have that at least 2-3 centimeters of length of intra-abdominal esophagus. Then we suture the hiatus. Now, occasionally we may need to use mesh, but most of us, especially if we're doing it for the first time, it's not a recurrence, we try to avoid mesh. As you know, there have been, again, in the media quite a lot, and there has been an inquiry as well about the use of vaginal mesh. So we do get lots and lots of questions about the use of mesh from patients, be it in inguinal hernias, being in hiatal hernias. So obviously, if you have something that is moving against the mesh, so if you put the mesh very snug around the esophagus, and the esophagus is trying to dilate and empty every time you eat, one of the risks, which is a terrible risk, is mesh erosion into the esophagus, and that is a terrible, terrible complication for the patient, and to a lesser extent for the surgeon who needs to deal with it. So what we do, repair the hiatus. I'll show you some pictures in a bit, and we also use the fundus, so that bit of stomach on the greater curvature, to wrap it around the lower esophagus to make it stronger, because since the lower esophageal sphincter has been in the chest for a while, it usually does not function properly, even if you get it down. And the strap, there are various operations which really is not the remit of the talk today. Lots of gastroenterologists and surgeons discuss this for meetings ad infinitum, as if you should do anterior, posterior, and if it's 360, 180. The more you wrap and the tighter you wrap, the more patients may get dysphagia post-op. But on the other hand, it may, if you do a lesser wrap, it may result in recurrent symptoms or in persistence of symptoms. So most surgeons have their own operation that works for them and their patients. So here we can see the hole in the diaphragm, right cross, left cross. In the middle, there's the fascia over the aorta. And you can see where the instrument is, the esophagus there. If you look very closely, the posterior vagus can be seen as well. That is the crural sutures there. Again, this is something that expands, so you don't want to go very, very tight, but you just put it snug. And that's a 360 posterior wrap. So the fundus is coming all the way round the esophagus from the back and suture to itself at the front. That's what it should look like post-op. Some people routinely endoscope as they finish the procedure. Now, regarding complications, there are the general complications of any surgery: bleeding, infection, DVT, PE. As we could see from the anatomy slides, there are lots of surrounding structures, like the esophagus itself, the lining of the pleura's there, the liver, the spleen. There are the blood vessels coming from the spleen. As you know, the fundus and the spleen share the common blood supply. There's the IVC on the right that can sometimes be very close to the right cross. Yeah, so arterogenic injury, there's the vagus that runs on the esophagus itself. Sometimes that can be pranged, injured, and may give the patient some diarrhea, which is either temporary or permanent. One may need to open up and do an open operation. And then there are the complications related to the fundoplication itself, like dysphagia. Most patients would have a bit of dysphagia early on, so most of us would say initially have either a liquid diet or a very soft diet for the first couple of weeks. Sometimes when you tighten, there's what we call gas bloat syndrome, i.e. the patients can't vomit, and then they feel very, very bloated because they can't vent up. What we said about the transient lower esophageal sphincter releases earlier. And then some patients also come to us and say that they are passing more flatus because they can't vent upwards, so the air needs to go somewhere and it goes downwards. With time, there can be recurrence of symptoms. So on the whole, most people think that PPIs and surgical treatment, more or less long-term, are equivalent. There's a new kid on the block, the magnetic sphincter augmentation. Again, it's a series of magnets that's placed around the lower esophageal sphincter. You don't usually use it for big hernias. And again, the problem that some surgeons have with the concept is having something that's more or less, like a rigid structure, even though it opens and closes, but more or less a rigid structure around the esophagus. In the past, we had a device called the Angelchik device that used to be like a sort of ring around the lower esophagus. It definitely didn't open and close like the Lynx, but the problem with that was that it used to sometimes erode in the stomach or migrate. So most people still are a little bit reluctant to offer this. Some people do. The other option is the endoscopic therapy, and what it is endoscopic RF ablation of the lower esophagus. And the theory behind that is once the patient has radiofrequency ablation, then the theory is that the muscle hypertrophies become thicker, and that may prevent reflux. Certainly, it's usually not used in large hiatus hernia or where there's severe esophageal esophagitis. Certainly not in Barrett's, because you might ablate the mucosa and have little nests embedded there. And it's certainly not if the motility studies are not quite right. So just to conclude, reflux is common. Most patients don't require investigations or surgery, but beware of the red flag symptoms. Thank you very much.
Thank you very much, Cynthia, for an excellent presentation. There are about 7 questions which the participants have put across to you. One is, Are the symptoms and signs of hiatal hernia same as GERD?
So patients can have reflux without having a hiatus hernia, and patients can have a hiatus hernia without any symptoms. In some patients, they coexist. So you can have one without the other. You can have a large hiatus hernia and no symptoms at all. And that's one of the reasons why sometimes we do endoscopies before our bariatric surgery, because we want to know what the anatomy is like. On the other hand, patients may have, you might have a look down, see nothing at all endoscopically, but when you talk to them, when you do the manometry, the pH studies, they do have obvious reflux.
One is, how does fundoplication help in GERD?
So it helps because we're trying to reconstitute the anatomy. We're trying to reconstitute that complex by narrowing the crural opening. Yes, sometimes you go in and the opening is about 4 or 5 times what it should be in normal patients. And you're also reinforcing the lower esophageal sphincter by that fundoplication, by putting the fundus around the lower esophagus to a larger or a smaller extent, depending on the type of wrap that you do.
The one is, won't surgery cause scarring and in turn affect the motility of food down the esophagus to the stomach? And again, in 360 fundoplication, what are the chances of narrowing the esophagus?
Whether the operation can actually cause scarring.
Scarring, affect the motility, and cause narrowing of the esophagus.
Yeah, so that's what I was saying by dysphagia. You can quite easily overcook it and overcompensate, and you can make a patient not have any reflux at all by making them completely dysphagic, so nothing comes up. But nothing can go down. So that's definitely not a good situation. So that's why all patients having surgery have that manometry, so that we know if someone has very, very little motility in their esophagus pre-op, I would be very, very hesitant to offer surgery. And if I do offer surgery, I will consent the patients to say, listen, this is more likely to happen in your case, dysphagia. If the pump on top is not pumping well, then it may be a real problem.
Right. And any dietary advice for post-op patients?
In my practice, I would usually say a couple of days of a liquid, sloppy diet. Then they go home on a sort of soft, pureed diet for about 7 to 10 days, and then depending on how they're doing, then proceed to a normal diet. Certainly, you need to tell them to chew very, very, very well. What you don't want them to do is for something to be stuck, when there's edema there, because then you have to go in endoscopically and try to take out the food bolus. So I tell them to sort of err on the side of caution usually, and to build up slowly.
And how do you measure a large hiatus hernia, which is more than 2?
Oh, it's large. Usually most of the paraesophageals are large. Anything that's, for me, anything that's more than 5 centimeters is when you're scoping, and it's more than 5 centimeters, then I've never so far encountered an esophagus that I couldn't get enough length. I think there are some people say that if you don't have enough length, you haven't mobilized as much, whereas there are some people who believe in this shortened esophagus, that it's chronically up there. Personally, if it doesn't come down, I keep on mobilizing, but then obviously there are the pulmonary veins and arteries that are coming quite close if you go to the to the middle of the mediastinum. So, it's I would say sort of 5 centimeters or anything that's paraesophageal.
Last but not the least, they've asked, how do you manage an upside down stomach?
Okay, so upside down stomach, I think what they're saying is a volvulus. Yeah, certainly sometimes you do see upside down stomachs on CTs that are the patient maybe has a bit of bloating and nothing else, but certainly it can be an emergency, and we know that this is usually in the context of a paraesophageal hernia when there's a volvulus, and then the chances of acute ischemia and is much higher. So if the patient is fit for surgery, in my practice, I would offer them an operation.
Thank you very much, Cynthia, and thank you all participants for your very interactive questions. So I'd like to take this opportunity to remind all of you that the next upcoming webinar is about understanding surgical anatomy and pathology of the breast, basically benign breast disease, on the 8th of September. I also would like to remind